maxillectomy on an on a Samoyed for looks like an odontogenic fibroma is what they said on histopath, although it looks more to me like a acanthomatous ameloblastoma. Incidentally, it had another one on the mandible that we removed a couple of years ago with good results. So I've never seen it happen in two different places in one dog, so that's interesting. Anyway, if you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. So what I'm doing here is the mass is sitting right here, and I'm going to go back to the canine teeth and probably a little bit beyond. So I'm going to go kind of at an angle like this in order to get our complete margin. Let's see here. Sophie, can you lift up on that for me a little bit? And I'm just going to separate the gingiva off the maxilla first to get my soft tissue margin. And usually when I'm doing maxillectomy and mandibulectomies, I try to separate as much of the soft tissue as I can and isolate the bone so that when I go to cut the bone, if I get a bleeder, it's basically completely separated except for the bone itself, so that I'm not stuck with a bleeding mess that then I can't access the bleeders. And just look at the cautery. Can I get you to please come around and push blend? Let's see if that works a little better. And let's see if that works. Still not doing a lot in the way of cautery. I'm testing this electrocautery machine because everybody's always asking me what electrocautery they should buy.
Maybe not this one.
And I must have one of the settings wrong because it's not as energetic. Can you turn it up to 50 and 50? I guess the other possibility is that since it's a Samoyed, it's not...
I did wet it wrong, apparently. She wet it wrong.
Yeah, not... try pushing soft. Let's see if that does anything.
Taking the colour off.
So go back to the other one then on blend. Blend is already on, so do power or forced. And then let's see. It is coagging. Just not as energetic as some of the ones that I've used before. So again, I'm just trying to separate out the soft tissue before I make my cut through the bone. The idea being that once I start making my cut through the bone, if I get a bleeder, I want to be able to separate it out quickly and not have to wrestle with the soft tissue as I'm trying to find my bleeders. Actually, the cautery is actually working quite well now.
Have a longer tip.
No. Okay, that's great. So you can let that go there. So now I'm going to cut through the gingiva here, and this is usually when it's going to start bleeding. Like that. And all right, so if we just keep some pressure, and sometimes if you put pressure back here, it can help as well. Do we have a saw blade? Is it, sorry, there's no saw blade? Can I get a medium saw blade, please? That one.
Digits to the digital pressure?
Yeah. And these basically don't stop bleeding until you get rid of the...
Oh, yeah, interns' hands get tired.
Yeah. All right, so let's see what we got here. So I'm coming through here. Can I get a... I don't know if this is...
Sound like it's losing power.
Yeah, it sounds like it is. Yeah, can I get a new battery, please? The osteotome. I think that's working fine.
Old school.
Alright, so now we'll come around on this side. Whenever you're using an osteotome, it's really helpful to make sure it's really sharp, like these. So it's almost as sharp as a scalpel blade here. All right, so that's our tumor sample there. So we've removed that, just make sure you can see that. And then we'll just administer, put in some pressure there. Let's see if we've got any major bleeders. Nothing really.
Sizzle. Just really took that last bit of soft tissue out of there.
Yeah, that cautery's not working so well.
Can we get the other ones out?
Yeah, please. We'll get our don't worry about it, Camille. We're all good. Yeah. No, that's all good. All right, so let's see if we can grab onto that lip. And you can release your fingers there. All right, so I don't know that I'll be able to, I think I'm just going to do a primary closure. Can I get some OPDS, please? Sometimes I'll try to drill some bone tunnels. To try to get some anchoring, but I'm not going to do that in this case. And this one, so there's a question, for an oral malignant tumor, would you always get a CT and a biopsy? And generally, we do. Try to get a biopsy and find out what we're dealing with before we try to remove it, because there's a wide variation in tumor behavior based on the histopathological type. So, Camille, I'm so sorry. I reckon I am going to need that cautery. And so when you think about oral tumors in dogs, there are 5 tumors that we commonly think about, and that's the way you remember it is foams at the mouth, F-O-A-M-S, so fibrosarcoma, osteosarcoma, acanthomatous ameloblastoma, melanoma, and squamous cell carcinoma. And those tumors all have very different behavior depending on the tumor type that we're dealing with, and so it is a good idea to know beforehand. This was biopsied as a fibromatous odontoma. It looks to me more like an acanthomatous ameloblastoma, grossly, so that's my working assumption. And just, yeah, you can just move the cautery across to the other one. Let's see if it works better now. It's definitely better. It's not a massive difference. Thank you. All right, so I'm getting a pretty big bite here. And often what I do with these is pre-place my sutures. Can I get a bunch of hemostats, please? Yeah. There's a question about, with the rostral maxillectomy, can I change the position of the nose? If you retain the canine teeth, then you're not going to significantly change the position of the nose, whereas if you remove the canine teeth, you can get a significant dip in the nose. And so that is something to be aware of. Can I get a couple more packs of 2O PDS, please?
2O or O?
This was 2O, wasn't it?
That was O.
I'll go O then, please. I think that was 2O.
Yeah.
This is definitely O here.
Sorry, it was in the O box.
That's all right.
Would you like a O or 2O next?
We'll go 2O. I mean, we'll go O.
Okay. Thank you.
Okay. Thank you. And it's important to use a taper needle so that you don't tear or cut the gingiva.
There's some more questions, Charlotte.
Yes?
Could rostral maxillectomy possibly,
I think
change the...
Yeah, I answered that one.
Sorry.
Yep.
When you're not able to close the wound primarily, then would you consider any type of flap or leave it for healing by second intention?
So in this location, you could do healing by second intention, and what will happen is if this dehisces, which they do sometimes, we will just let it heal by second intention. That being said, like in this far rostral, it's hard to do a flap because nothing really reaches there easily, although you can do it's called a complex facial flap or bicularis oris, axial pattern flap, which is really good for some oral or facial defects. And I'm trying to bury my knots so that they're not as irritating in the mouth. All right, so I'm going to start closing. Did I lose it?
It's just
Where?
give me some debate, some out to get him.
Nope. Silly me. Yeah. So if you had to choose an oral tumor, this is the one to have. I think probably the worst one, with the highest chance of it affecting longevity, would probably be an oral fibrosarcoma. So even though they don't have the highest chance of metastasis, they very definitely have the highest chance of local recurrence. And I would say probably about 50% of the oral fibrosarcomas that I remove surgically recur. Melanoma is also a bad one and has probably the highest chance of metastasis. So oral melanoma greater than about 4 centimeters only has about a 20% chance of being alive at the end of a year with surgery. And so generally, we recommend, like often I'll just do palliative radiation therapy on those, and you get a median survival time of about 9 months just with 3 doses of radiation. The other thing that you can consider would be a tumor vaccine with those as well. So you treat the primary tumor, and then also you give tumor immunostimulation using a vaccine, and that can improve the survival time as well.
It's quite expensive, isn't it?
Yeah, Sarah's saying it's quite expensive, which I think it is. Just be careful.
You need accreditation or something.
Oh.
206 there.
Spent the evening last night teaching my youngest son more about suturing and plastic surgery techniques. He's a third-year medical student, starting 4th year, and he wants to be a surgeon.
Sure. Everybody in the ED thanks you.
What?
Isn't that what the new doctors do, all the lacerations in the ED? The suturing?
Yeah, why would they hate me?
No, they would thank you, I
Oh.
said.
But you were
Cracking
saying
up.
they hate me.
I was like,
It's a bit rough.
oh, you know that's me.
And Sarah, I hate to say it, but my oldest son, who is 2 years out from medical school, just got his 10th publication.
Do you want to do mine too?
So you've got some work to catch
I'll
up.
give him some chocolate.
And he is a huge
Can you write a
overachiever.
book as well?
Section.
A section. Oh, only a section. Well, you know, can't have everything, can you? Do you know the most annoying thing? He's a very nice guy as well.
Yeah.
Someone's asked
So it depends on where you go. I think that's cut through. Our radiation machine is relatively inexpensive at about $5,500 for a full course, but it's nowhere near as good as the linear accelerator that they have in Brisbane and in Sydney. And those you're talking about kind of 12 to 16,000 for full course, so it is very expensive. But they've got amazing human level machines there. And our machine is a human machine. There's still about 40 of them being in use in Australia in humans, but it is very old technology, and so we can only do kind of superficial treatment. All right, so what we're going to do now is we're going to remove all the drapes and see what we look like cosmetically. I think we've got a little bit of a dip here. It's not too bad though. Sarah, have you done infraorbital nerve blocks before?
Yes.
Okay, so we'll do some lignocaine, or sorry, some mepivacaine into the infraorbital nerve. So that's what it looks like cosmetically. So I'm pretty happy with that. And we'll go ahead and do our nerve block. I'll come over and see if there are any questions that I haven't answered yet. Hi, Ramesh. And Piyush. South Korea, Toronto, Colombia, Japan, South Korea, Pakistan, Hong Kong, Gainesville. Hi, Gainesville, go Gators. Houston, Texas. You can use a TPLO saw, somebody has suggested. They work really well. Oklahoma, Lima, Peru, Cairo. So that's pretty much it for me for this case. I do have a lot of surgeries today that I'm hoping to live stream. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications. And then I've got what do I have? An injection site sarcoma in a cat, a mandibulectomy, and a tibial crest transposition for patellar luxation. Anyway, nice chatting with anybody, and we'll talk to you again soon.